Bismillahirrahmanirrahim. We are starting our session. This is pediatric surgery session, and we'll start with the talk of Dr. Ong Lin Yan, who is head and senior consultant pediatric surgeon at the KK Women and Children's Hospital. Her subspecialty interests are minimal invasive and thoracic surgery. Dr. Ong's Health Manpower Development Plan fellowship year was spent in Paris at Hospital Necker Infant Maladies. She was placed under tutelage of Professor Jan Ravillon, a pioneer in pediatric thoracic surgery and a strong proponent of minimal invasive surgery. Dr. Ong is also actively involved in teaching and education, holding the position of clinical faculty for the general surgery residency program, as well as advanced specialty training director of KKH pediatric surgery and advanced surgery trainees. With this, I would I would start the talk of Dr. Ong Lee. Dr. Ong Lee.
A pleasure to be invited to give this talk on thoracoscopy in children at ICON 2022. Okay, my talk is entitled Thoracoscopy in Children, Tips and Tricks, Choosing Patients and Pathologies. The first thoracoscopy was performed by Jacobius, a Swedish physician in Stockholm, using a modified cystoscope, and this was published in 1910. In the 1970s and 80s, the first significant experience in children was reported by Rogers and his co-workers in Annals of Surgery. They used equipment modified for pediatric patients and performed lung biopsies, evaluated various intrathoracic lesions, and performed limited debridements of empyemas. Pediatric thoracoscopy then gained popularity in the 1990s, enabling more advanced diagnostic and therapeutic procedures to be performed. The adult surgeons have it pretty easy. Once the lung is collapsed, the pressure of the carbon dioxide creating the space within the thorax can be decreased, the incision is then widened, and several instruments can be inserted in the same incision without the need to maintain a seal. This is called the utility incision. Currently, uniportal VATS is fast becoming the standard of care for lung resections. In pediatric surgery, we have a similar incision. We call this a thoracotomy. Pediatric thoracoscopy is challenging, to say the least, but while this does not apply to some of our more robust patients, for example, this teenager with a pneumothorax, we are now performing thoracoscopic procedures on younger children, such as this 5-year-old with empyema thoracis, and toddlers like this 2-year-old with an infected CPAP. As you can imagine, toddler's body does not offer a wealth of space, especially within the thoracic cavity. As more surgeons attempt to break the barrier of size, pediatric VATS is becoming more and more challenging. But to put it plainly, size matters. When discussing surgical options, one of the most common questions is, how big will the scar be? I might do a wonderful job on the inside of the chest, but patients and parents are only looking at one thing, the final scar. As a parent, would you prefer your child to have these scars? Or would you opt for something like this? This? Or this? I think the pictures speak for themselves. Incisions such as these have also been shown to reduce post-operative pain, enable faster mobilization, and hasten post-operative recovery and discharge from hospital. Unlike adults who are already fully grown, children are still growing entities. Any muscle-cutting incision can have deleterious effects on musculoskeletal growth as the child gets older. Examples of these are deformities sustained from childhood posterolateral thoracotomies. Traditionally associated deformities include pectoral muscle maldevelopment, rib fusions, winging of scapula, and scoliosis. Although a variety of muscle splitting incisions have been described, these do not totally eliminate the source of these complications. In children, the vast majority of thoracic conditions encountered are congenital, such as CPAMs, esophageal atresia, foregut duplications, congenital diaphragmatic hernias, and acquired, such as infective conditions, pneumothorax. We very rarely have to deal with cancer. As such, the organ to be removed can actually be taken out piecemeal through a very small incision rather than having to enlarge the incision to remove the entire organ intact. MIS also confers the advantage of improved visualization and magnification, and this is no different for surgery in the chest cavity. It was quickly realized that thoracoscopy offered an operative view that was far superior to that in open surgery, and this has continued to improve with advances in optical technology. On the left, you see the patient with an open esophageal atresia repair, and this is one of the best photos that I've seen in my more than 20 years of practice. On the right, you see the appearance in the thoracoscopic esophageal atresia repair. The magnification and quality is far superior, and you can see why many people would flock towards this form of management. We now move on to some of the must-have and must-knows for pediatric thoracoscopy before you can even get started. Ask any thoracic surgeon, the bane of thoracic surgery is poor lung isolation. We are fortunate at KK Hospital to have an excellent bunch of anesthesia colleagues. They take great pains to help us achieve the desired lung isolation for the surgery required. Our adult colleagues are favored with an excellent range of double lumen tubes, and these enable rapid and accurate isolation of the lung to be collapsed. Unfortunately, the smallest available double lumen tube is a size 28, and this is only suitable for a child of about 30 kilos, and that is a decent 9 to 10-year-old in Singapore. The ANT blocker is used for younger children. It is a broncho blocker with a low pressure balloon designed to go through an endotracheal tube and piggybacked onto a bronchoscope. The smallest ANT blocker requires a size 4.5 endotracheal tube to accommodate both it and the accompanying bronchoscope. This brings us down to a 1 to 2-year-old toddler. Our last resort for infants is the Fogathy Catheter. Most of you will be familiar with this name. However, this catheter was not devised for use as a bronchial blocker, and we have had to make adjustments, but it's used to prevent pressure effects on the affected bronchus. Success with this technique cannot be guaranteed, and if not deployed properly, it can even create a one-way valve resulting in persistent inflation of the lung that is meant to be blocked. It also doesn't work well for the right lung due to the higher takeoff of the upper lobe bronchus. If your anesthetist doesn't have any of these fiddly devices, a selective bronchial intubation may be all that you need. The positioning for surgery will differ depending on the organ and the area of the chest that you intend to operate on. Always set yourself up to succeed and leverage on gravity to help you with the exposure. These pictures demonstrate the effect of gravity and different body positions on the position and accessibility of the intrathoracic organs. It's important to identify the area of the thorax the operation is to take place, and then position the child accordingly. The picture on the left shows an anterior lesion, such as a thymic cyst or a bronchogenic cyst. The one in the middle shows our standard position for lung biopsies and thoracoscopic lung resections. And the one on the right, which is sort of like a flopped over position, is more for posterior lesions, like, for example, a ganglioneuroma or operation for esophageal atresia. In adult thoracic surgery, it's routine to so-called break the bed, and this increases the distance between the rib spaces to facilitate exposure. In children, sometimes a jelly roll or a cloth under the lower ribs will do the same thing. As you can see in the picture, there are many attachments to the baby: the pulse oximeter, the catheter, the diathermy pad, and other devices for monitoring. It is important that this may be a prolonged surgery, and temperature is an issue, and it's important to pad all the pressure points and make sure all these tubes do not get entangled when preparing for surgery. Positioning alone does not ensure success. The patient is not the only one in the room, and in thoracoscopic surgery, a large amount of space has to be occupied by the equipment. For a 10-kilo toddler going for thoracoscopic lobectomy, this would be the ideal operating setup. The small size of the child provides only minimal space around it for surgeons to stand and operate. Every child is different, so all positioning has to be pre-planned and optimized for surgery. Monitors are as shown, with the main monitor in line with the surgeon's view, as well as a slave monitor for the scrub nurse. An OT huddle prior to surgery will help your team understand all the necessary requirements. A cohesive scrub team is essential to the success of this procedure. It is important that everybody is aware of what the aims are of the procedure and where everybody needs to be and who is in charge of doing what. Perfect placement of ports is also essential in thoracic surgery. Unlike in abdominal surgery, it's not possible to partially compensate for poor placement by using force. The ribs are rigid and the port stays in the position that it is placed. In a small child, there's little room for error. Wrong placement may mean that the scope is impeded by an outstretched arm and the view in a certain direction is limited. These pictures show the port placement for a left lobectomy. The first port is in the fifth intercostal space in the mid-axillary line that's placed to overlook the oblique fissure. This is where most of the action is expected to take place. The upper port is placed 1 or 2 rib spaces above. This can be a 5 or 3 millimeter working port. And the lower port is placed where the ribs are wider and the incision can be extended to accommodate a 12 millimeter staple device. In certain cases, a fourth port at the tip of the scapula may be added. And it is also useful to mark out your thoracotomy site in the case that you might need to convert this case to an open thoracotomy. This is the appearance of some of these incisions at the end of surgery. As you can see, the fourth port site was not required, and the chest tube can emerge from either the camera port site or from the lower extended incision. Over the years, instruments have also decreased in size, and so have our patients. The pioneers of peds thoracoscopic surgery made do with what they had and modified existing instruments to suit their purpose. We have moved from 10 millimeter scopes to 5 millimeter scopes and now 3 millimeter scopes. And thankfully, there are now companies offering a range of these short 3 millimeter instruments suitable for thoracoscopic work in neonates. Though some instruments have decreased in size, others remain limited by technical issues. The space between the upper ribs in a 1-year-old can barely fit a 5 millimeter port, and any attempt to force such a port between the ribs can cause nerve damage to the intercostal nerve. To utilize a 12 millimeter staple device, we have to lubricate liberally and literally force it through the lower ribs, risking a fracture in the process. There is also no room to maneuver as the chest cavity is very short, and it's technically difficult to get sufficient clearance over pulmonary vessels to apply the staple. This leaves us with 2 options. We can either suture the bronchus and ligate vessels individually, or we can create our own instruments. Steve Rothenberg, in his thoughts lecture in the 2015 IPEC, detailed his journey of innovation and development of his 5 millimeter staple and 3 millimeter vessel sealing devices. This is what the standard 12 millimeter staple looks like, and this is his 3 millimeter just right staple device. The comparison between the two, it's obvious how much finer the innovated staple is. In addition, other devices are needed depending on the operation to be done. Vessel sealing devices, clips, retrieval bags, and tissue sealant. The surgeon should create a preference list for each operation, and this can be given to the scrub nurse for preparation the day before. Our trainees also attend basic and advanced minimally invasive surgery courses. Advanced Thoracoscopy is one of these courses, and it's held together with adult cardiothoracic trainees. We also have the advantage of training and proctoring by local as well as overseas experts in the field, and you may recognize some of these people in the pictures. As surgeons, we recognize the need to continually improve our skills and have attended workshops such as the one run by ERCAT. We've run our own workshops locally, and we've used our simple thoracoscopic operations as a means of developing skills required for more advanced surgery. Skills will only improve in practice, and for this we have set up a little cozy corner in one of our consultants' desks. And essentially, nobody should be playing or practicing on patients, but we should hone our skills in the dry labs and then take these to when we finally operate on patients. We can create your own simulated cases and acquire skills like intracorporeal suturing outside of the operating theatre. And now we can get started. Decortication for empyema thoracis forms the main indication for VATS in our department. although early chest tube insertion and installation of urokinase has avoided the need for surgery in a select few, prior to COVID, we used to perform an average of 20 VETS decodifications each year. This procedure was the mainstay for training for thoracoscopic procedures in our department. This is akin to appendicectomy for abdominal procedures. When faced with a loculated collection such as this, the trainee can learn many techniques. This includes the camera setup, positioning of the patient, fostering good communication with anesthetists and nurses, how to select the site for the first port insertion, the technique of safe port insertion, techniques of triangulation, learning to work through viewing pathology from different angles, manipulation of instruments, appreciation of complex anatomy, and very gentle handling of tissues. As you can see in this video, this is one of our trainees who's doing the empyema. And right now he is dissecting within the oblique fissure, and he's trying to free the fissure and remove the peel so that the lung can expand. He has to be very gentle because this is very friable lung tissue, and any force may actually puncture the lung and cause prolonged air leak. So the white gunk is the peel, and he is gently teasing it off the surface of the lung. And of course, the last skill that they learn is how to put a chest tube and how to secure it in place. Not all children requiring lung biopsies are candidates for the thoracoscopic route. Thoracoscopic lung biopsy requires lung isolation and pliable lung tissue. Many patients are very sick in the ICU, have problems tolerating ventilation, supine, let alone in the lateral position where one lung is dependent, and there will be a VQ mismatch. In a case like this, it's a patient with hemosiderosis. This child had saturations of 88% on room air. The lung was solid, difficult to ventilate, and this biopsy was done open. In contrast, this is a case of a child with acute myeloid leukemia with a fungal infection in the upper lobe. This was a solitary lesion, and the child was very stable with good saturations on room air, and this was suitable for thoracoscopic biopsy. So on introduction of the scope, the site of the lesion is evident, and after detachment from the posterior chest wall, the lesion is held with an artery, so you don't necessarily need to use standard laparoscopic instruments. Okay. The lesion is held with an artery from the port site, and the bowel grasper was first introduced to assess if it would be suitable for introduction of a staple device, which has now been inserted. And it took about 3 staples, but the lung has been wedged and the lesion has been removed entirely and is being retrieved using a bag. In cases where active infection is expected, it is better to place the specimen in a bag and remove it without compromising the chest wall incision. Spontaneous pneumothorax is not very common in our population. They are usually managed by the respiratory physician, and we only get the patients who are referred to us for surgery. At KK, we follow BTS guidelines, which is the British Thoracic Surgery Guidelines, but these are generally applicable more for adults. Accepted indications for surgery include second ipsilateral pneumothorax, first contralateral pneumothorax, bilateral pneumothorax, persistent air leak, spontaneous hemothorax, and plan to be a certain profession that might be at risk, for example, divers or pilots. CT scan is only recommended for uncertain or complex cases. And surgical options include tap pleurodesis, mechanical pleurodesis, and an apical pleurectomy, which is usually done via thoracotomy. Our team recently reviewed our patients with spontaneous pneumothorax and found a couple of interesting things. Number one, interestingly, surgery at the time of first presentation was predictive for a contralateral occurrence. And second, that CT scan was not sensitive for the detection of blebs and was not able to predict the need for surgery. In children with obvious bullae, such as this one on the chest X-ray, there is no CT scan required. This child had persistent air leak despite chest tube being on suction, and so was referred to us for consideration of surgery. Thoracoscopy is the rule when surgery is required for the pneumothorax. As you can see, the lung has been well isolated. There is an enormous bulle that is clearly evident. And at this point, you can see the lung is being held to the chest wall by a vascularized adhesion, contributing to the persistent air leak. As the adhesion is being freed, it becomes evident that there are more bullae that are deep to the one that is obviously seen, and all these are required to be wedged and resected. And this is done with a staple device. Once the bullae has been removed, then we can opt to do one of two methods of pleurodesis. This is mechanical pleurodesis, where we use a diathermy scraper and we wrap it around an artery and then we scrape the chest wall. We used to do this very regularly until we reviewed our results and discovered there was an up to 30% recurrence rate, after which we have stopped using this method and we now resort to the second method of pleurodesis, which is a talc pleurodesis, which you can see over here. And to do the talc pleurodesis, we actually have this little device, which allows us to put the talc in the little bottle and then use a pump to push air together with the talc into the pleural cavity. And this creates an inflammatory response, sealing the lung to the chest wall. We move on to congenital lung lesions. The majority of our patients with congenital lung lesions actually have an antenatal diagnosis because of our very good antenatal screening. And this is usually detected during the screening scan at 20 weeks. The fetus is monitored for risk of hydrops. Certain indices, such as the observed over expected cCam to volume ratio, are determined, and presence of a feeding vessel is noted. That would signify a diagnosis of a sequestration. They are counseled by obstetrics as well as the pediatric surgeon, and delivery is usually via normal delivery if there are no other contraindications. At the time of delivery, the baby is assessed by the neonatologist and resuscitation is effected if required. If the baby is stable, the baby goes to our special care nursery. However, if the baby is unstable, the baby might be intubated, require supplemental oxygen, and is monitored in the ICU. In either case, an X-ray is done looking for nature of the lesion, any mediastinal shift, and pneumothorax, or any other problems. Once the ICU baby is stabilized, the baby moves on to the special care nursery. However, if there are problems with ventilation and we are unable to wean the baby off ventilation, then a CT scan is done early within the first 1 or 2 days, and then we may consider early surgery. For the SEN baby, if all is well, the baby goes home and is on outpatient follow-up, and this is done 3 to 6 monthly with an X-ray. At the age of 1 year, we perform a CT scan, and following that result, then we decide either for surgery or continued observation. It is important to have the correct medical indications for surgery. In young children, we need to seriously consider two things: radiation risk and anesthetic risk. Unfortunately, CT scan is still the best modality for evaluating the lung pathology. It is routine in some parts of the world to do a CT scan just after birth and proceed with surgery within the first 3 months. At this age, the cancer risk to the neonate from the single CT scan is way higher than if the child waits for about 1 to 2 years. This is a 1-year-old with an antenatal diagnosis of a lung lesion. This lesion was noted to have a feeding vessel, making it extralobular sequestration. This lesion does not communicate with the airway and is of low risk of infection, and some of these have been known to resolve spontaneously during the first year of life due to diminishing blood supply. We modified the port sites to suit our pathology, enabling a proper triangulation. But here you can see on the thoracoscopic view, the sequestration is clearly seen. And this is the pedicle, which is currently covered with pleura. Again, this is one of our junior trainees doing the surgery. He's taking the pleura off and then isolating the vessel. It's important to take the pleura off the vessel. If not, your clips and ligatures may slip, and that can cause intrathoracic or sometimes even intra-abdominal bleeding, depending on the origin of the vessel. Here he is using Hemalox. He is also doing a little bit of practicing. He's trying to do his intracorporeal suturing and tie. And because he is still quite junior, he decided to put more hemolocks to secure the vessel. He thought he had only gotten one vessel, but after he divided this pedicle, he had realized that he had gotten both the artery and the vein at the same time. This is not something I would generally recommend, but in this case, it should not be too much of a problem. Having resected the sequestration, it is then removed from the lower port site piecemeal, and this enables a very, very small incision to be made. We then move on to an intralobular sequestration. This child had the left lower lobe intrapulmonary sequestration with the feeding vessel arising from the thoracic aorta. Differs from an extralobular sequestration in that there is a communication with the airway and therefore a higher risk of infection. In this video, we can see the evidence of the sequestration. On introduction of the scope, the simple dissection confirms what we know from the CT scan that the feeding vessel originates from the thoracic aorta. It's important to dissect an adequate length of the vessel for a safe division, and that also prevents retraction of the vessel subsequently. In this case, we are also using hemolock clips. But this vessel can be managed either with hemolocks, ligatures, or even a staple device. Following division of the feeding vessel and the disruption of the arterial supply, the lesion will become more clearly demarcated. In this case, because it was a very small lesion, the surgeon was able to do a wedge resection of this intralobular sequestration. In the case where the lesion is larger and occupies a large portion of the lobe, a lobectomy will be necessary for complete resection. We now move on to CPAMs, congenital pulmonary airway malformations. There's been significant differences in management on both sides of the ocean. The Americans tend to evaluate and operate early, and they claim that surgery is equally safe between 1 month to 1 year, and early surgery is associated with decreased operative time. On the other side of the ocean, the Europeans tend to prefer the watch and wait approach, and this long-term study by Gosh shows that the infection rate is actually less than 10% and actually decreases after the second year of life, and they did not detect any cases of malignancy. We continue on our journey in complexity. We move on to the Thoracoscopic Lobectomy. This is a CT scan of a patient with a left lower lobe type 2 CPAM. There's no feeding vessel to suggest a hybrid lesion. The lesion is purely confined to the right lower lobe, and in some patients, the CPAM may occupy more than one lobe, and that needs to be considered when planning surgery. There is no mass effect. There's no evidence of any infection and inflammation. In view of the size of the cyst, this would be a candidate for surgery. Compared to this patient has got cysts of significant size. However, the cysts occupy 2 lobes, and it is not feasible to do a pneumonectomy for this patient. So this is a patient that you might want to watch and wait, or if you decide that these cysts really need to be removed, you may wish to do a thoracotomy and a selective resection of these lesions. This is a third case with a very large left upper lobe CPAM, and this patient actually had a stormy period in ICU for the first couple of days. But in this case, you're not going to offer a thoracoscopic surgery. This child actually needed a thoracotomy and left upper lobe resection in the first few days of life. This is another child with an infected lesion. In this case, there are 2 options. One is you can wait for the infection to settle and then re-image with a CT scan and determine whether this case can then be done thoracoscopically. The alternative may be to proceed with a thoracotomy and a resection if the infection does not settle. So this is a video of a thoracoscopic left lower lobectomy, similar to that first case that you saw just now. There are a lot of important structures within the thorax, and a knowledge of anatomy is very important. Some things to note: there is a very good view, okay? And there are lots of important structures within the thorax. The unsteadiness that you see is not due to the poor camera holding skills, but it's actually due to the rapid beating of the child's heart. And we are unable to avoid having that problem. Right now, you can see they're going to the inferior pulmonary ligament. After dividing the arteries to the lower lobe, we are now looking at the inferior pulmonary vein. At this point, let me point out that the Ligamax clips that are being used should be applied over the entire vessel. As you can see, the surgeon here is not happy with the first two applications and therefore is putting a third clip. Having taken the arteries and the vein, the focus is on the preparation of the bronchus, and it's important to make sure that you only clamp on the bronchus supplying the lower lobe and do not disrupt the bronchus that goes to the upper lobe. And over here, we're using the staple to complete the lobectomy. This is another patient with a left upper lobe CPAM. In this case, the cysts are similar. There is no mediastinal shift. However, there is a small mucus-filled structure in the axial and sagittal views, raising the possibility of a low-grade infection. It is timely at this point to raise the issues of lobectomy versus segmentectomy for CPAMs. It's important to note that CPAMs do not respect segmental boundaries. Segmentectomies are more complex. They require planning and intimate knowledge of anatomy, increased risk of an air leak due to long suture lines, and it requires visualization of the lesion, which is not generally the case if you do a thoracoscopic surgery. There is about a 15% risk of remnant CPAM following segmentectomy, and pulmonary function scans post-lobectomy have not shown any difference compared to normal controls, questioning the need for the patient to have a segmentectomy. This shows the left upper lobectomy for the patient in question. These are the port sites. Slight modification, putting the camera port in the posterior axillary line to have better triangulation to view the anterior mediastinal structures as the pulmonary vein, superior pulmonary vein comes from anterior. This is the superior pulmonary vein and its branches. Dissection is taking place. It is important to dissect these properly and to secure them with either clips. In this case, we are using a Ligamax, and then subsequently we are sealing using the ligature. When using the ligature or any energy device, it is important to be aware of the potential for dissipation of heat and energy. And this tends to be more the case with the harmonic scalpel compared to the ligature. Having divided the venous branches, the two branches of the pulmonary artery come into view. This would be the anterior and the apical posterior branches, and these are going to be similarly divided. In every case of lobectomy, it is important to do an anatomical dissection and identify and isolate each structure properly. We now move posteriorly where the lingular arteries are, and there are two of them. It is also important to be aware of potential variations in pulmonary vasculature anatomy. Having taken the arterial supply, we move on to cleaning up the oblique fissure, and this will help us to skeletonize and isolate the bronchus and complete the lobectomy. You can see that there are several lymph nodes around the bronchus, and this is evidence of very mild ongoing infection. Here the bronchus has been isolated. Once again, so this is the staple that is applied. And before we effect the staple, we will actually get the anesthetist to deflate the bronchial blocker and try to inflate the lower lobe so that we are sure, once again, that we have not occluded the bronchus to the lower lobe. The lobectomy is complete. The hilum is inspected for any bleeding, and there is a check for air leak. We usually use the Avicel tissue sealant over the hilar structures, and an appropriate chest tube is inserted. There are many other procedures that we can discuss, such as thoracoscopic repair of congenital diaphragmatic hernia, esophageal atresia, but there are whole webinars by themselves dedicated to these things, and it's not possible to have a meaningful discussion at this platform. Through this talk, we have gone through clear benefits of thoracoscopy and emphasized important points about getting started, must-haves and important considerations along the way in terms of training and acquiring required devices. I've then highlighted some conditions suitable for thoracoscopic interventions. In my view, these are in order of difficulty and level of experience of the surgeon and the team. With each condition, I have brought up some considerations with regards to the condition itself, surgical indications, and important notes in evaluation during surgery. My journey and growth as a pediatric surgeon, a pediatric thoracic surgeon, would not have been complete without these people. Firstly, Professor Niaz Jacobson, my then head of department, who on my first day at work asked me if I spoke French and if I was interested in thoracic surgery. Professor Yann Revillon, who was my mentor during my fellowship at Necker Enfants Malades in Paris. He's a thoracic surgeon and a strong proponent of minimally invasive surgery. There was Professor Steve Rothenberg, who was our HMDP visitor in 2013 and has pioneered many thoracoscopic surgical procedures, and he's the innovator of the Just Right surgical instruments and has created many learning videos online. Last but not least, Prof. Augustine, who's a adult thoracic surgeon, now in private practice, who was kind enough to mentor me when I first started out doing thoracic surgery. Most important in my acknowledgement list is this man. He's our OT attendant, Hairudin. Without him, it would be impossible to correctly position patients, move all the required equipment to where it needs to be, and he has single-handedly trained his other attendants to assist us in these procedures. So your OT attendant is one of the most important people you need to look for. This is Dr. Chen Yong, who has been responsible for editing many of the videos and has always encouraged us to innovate and push on with our minimally invasive endeavors. I want to thank Dr. Hannah for inviting me to do this talk. Dr. Hannah was our fellow, and she was a wonderful fellow when she was with us, and I'm very grateful for this opportunity. Last but not least, Pediatric Surgery Team B from KK Hospital, who has been for their long-suffering support in my thoracoscopic journey. Best wishes from the Department of Pediatric Surgery at KK Hospital. I thank you for your attention, and I will now take any questions.
Thank you so much, Dr. Ong Lin. And now floor is open for questions. The participants can write questions in the chat box, which we can see, and Dr. Ong can answer directly. So participants are invited to write questions in the chat box for Dr. Ong Lee. Since I don't see participants' questions, I have a question for Dr. Ong Lin Yen. Working in a resource-constrained environment, we are facing difficulties of acquiring these advanced instruments, and most of the times we have to improvise and we have to be limited with our resources. So what is your suggestion for resource constrained environments, and how do we establish training of pediatric minimal invasive surgery, and especially pediatric minimal invasive thoracic surgery? Any tips and tricks related to that?
So I think there are always alternatives to using fanciful instruments. For example, we don't have access to the 3mm instruments either because of certain lack of what we call HSA approval. But as I mentioned, as I alluded to earlier in the presentation, an alternative to using clips or sealing devices is actually to learn how to do a suture ligation of important structures. So you can actually ligate the bronchus, you can ligate the vessels using just normal ties. And I'm sure if your department actually has enough of these numbers, and I'm sure you have more numbers than we do, and that's your advantage. So you have to leverage on that, and you guys are going to get much better at this than we are, because you actually will develop the skills that not everybody develops when they have all these very cool and innovative instruments. So you know, we have to take we have to innovate in our own way, and we have to find ways to use what we have and then to do what we need to do.
Especially like we have a great load of empyema thoracis. As you said, that this is the most common procedure,
Mm,
minimal invasive thoracic procedure being done at your hospital as well. But our cohort is
mhm,
a cohort which comes later. Like
mhm,
our conversion rates goes higher because the peel is very thick to play with the thoracoscopic instruments. Here we are working hard. In fact, this is my comment from our side. Here we are working hard with pediatricians to refer early if they want vet's advantage. Otherwise, if we lose that window period of like 2 weeks, then probably it's already late, and vets would not be practical into that setup. But yes, this is in our setup also. This is the most common procedure which comes for thoracotomy or vets in our setup.
yes. And so because of that, you should use this procedure for your trainees to start developing their skills. And I think as time goes on, your pediatricians will also come on board and they will actually refer these cases in a timely manner. I think I agree with you that 2 weeks is a bit long. By that time, you've actually encountered with something like a fibrothorax where all the peel is really thick and it's not possible to do that thoracoscopically.
We have a question from your
Mhm.
pupil, Hana Arbab. For most lung pathologies, do you suggest we wait for a year where we can?
I think it also depends on how things work in your country. If you have patients who are going to disappear and not come back until something goes wrong, then
Unfortunately, that is the case.
you may want to catch them early and tell them, look, you have this problem, and you need to come back. There has to be some awareness there. For us, we are fortunate in that Singapore is quite a small country. It's difficult for patients to run away, and many of them will actually return for follow up. I would suggest when you're starting out and you're not so you're not so confident doing the smaller babies, then it is better to start operating when the children are older, maybe even like 2 3 years old, and then as you get more skilled and you get more used to the operations, and then you can go down to smaller and smaller sizes. There
Uh,
are advantages, yeah. Sorry, there are
uh, uh,
advantages to.
yes,
mm,
go ahead, go ahead, go ahead, doc.
There are advantages in operating on very small children. Actually, in the US, when they do these on 3 month olds or 6 month old, the fishes are actually generally very well developed. The structures are really small, and they can actually get by doing lobectomy quite fast. And that's an added advantage because most of these babies haven't gotten any infections and there are no adhesions, etc. So there are advantages to doing these kits when they're really small.
Okay, great. My question was related to this sequestration. Like you said, 1 year is cut off and you observe them for 1 year. But there has always been a debate for small sequestrations which are not causing problems. Having vets at hand, does it change your decision making? Like, for example, the 3 by 3 centimeter sequestration diagnosed incidentally in a 4-year-old child. Would you still wait, or do you have because of vets you go early and operate? What is your take on this?
So it will depend on whether this is an intrapulmonary or extrapulmonary sequestration. An extrapulmonary sequestration doesn't have a communication with the airway, and because of that, is less likely to get infected and cause complications. It may just stay there, in fact, for the rest of the child's life if you don't do anything. Whereas an intrapulmonary sequestration does have a communication and does have a propensity to get infected. So, if we suspect based on CT scan that this is an intrapulmonary sequestration, I would be more likely to push for surgery. If it's an extrapulmonary sequestration, we have often made a discussion with parents and then given them a choice to decide whether they would like this done or not.
We have one more question from Hana Arbab. We face a lot of resistance from anesthesia since the instability they face during thoracoscopy deters them to let us do these surgeries. How, as surgeons, can we reassure them, if at all?
Okay. Uh, so it's sort of like training your pediatricians. You also have to train your anesthetists. You do have to
Sure.
find they will have to understand that this is the start of your learning curve, that you can expect operations to take longer, and things would be a little bit more tricky. But they need to have that confidence that if you start trying and you have a problem, that you will know when to back off and convert to a thoracotomy, for example, and you will not push them beyond their limits. And as you move on in that learning curve and your times get better, your patients will be more stable during the surgeries, and then you will sort of move together in this journey of thoracoscopy.
Thank you. Thank you so much, Dr. Onglin. It was pleasure listening to your talk and talking to you. Thank you so much.
Thank you for
Now
having
we'll
me.
now we'll move to our second talk, which is by Dr. Niaz Hussain Soomro, who is an associate professor and chairperson at the Department of Thoracic Surgery, Dow University of Health Sciences. Dr. Niaz is a very busy and experienced thoracic surgeon, and he has done his fellowship from Royal College of Physicians and Surgeons of Glasgow, fellowship of American College of Surgeons, and he has trained from Florida, United States, for masters in minimal invasive thoracic surgery. He has like many original articles and case reports at his credit, and he has been kind enough in helping our team at Indus Hospital with these complex thoracic wall tumors, which require reconstruction of chest walls. So, with this, I would invite Dr. Niaz Hussain Soomro to present his talk. Dr. Niaz Hussain Soomro.
I'm Dr. Niaz Hussain, thoracic surgeon, Dow University of Health Sciences. We will discuss about resection and reconstruction of chest wall tumors in children. Chest wall tumors in childhood and adolescence can be very heterogeneous and may appear at any age from infancy to late adolescence. They can be benign and malignant could be primary or secondary. For all patients, we must take a careful history, physical examination, followed by imaging studies to delineate the primary tumors and identify possible sites of dissemination. The diagnosis usually requires needle or incisional biopsy. Most neoplastic tumors require complete resection surgically, whereas secondary are treated by chemotherapy or radiotherapy. But depending on the nature of the tumor pathology, so they may need chemo and radiation before surgery, neoadjuvant chemo or radiation, and sometimes adjuvant chemo and radiation. But the important thing here in the chest wall tumors is after resection, there is a reconstruction. And reconstruction is depending on the partial resection has been done or complete full thickness resection has been done. So rigid chest wall reconstruction has the advantage of eliminating paradoxical respiration. That's why decrease the need for and post-operative ventilation. And other advantage of rigid chest wall reconstruction, it maintains the contour of the chest wall. This brief a table indicating that benign and malignant chest wall tumors. So lipoblastoma, mesenchyma, mesenchymal hematoma, desmoid tumor, lymphangioma, and hemangioma are benign category. And in malignant one, the peanut, Ewing sarcoma, Langerhans cell cystocytosis, and malignant fibrocystocytoma, rhabdomyo and chondrosarcoma, osteosarcoma, synovial sarcoma, leiomyosarcoma, fibrosarcoma, and lymphoma are in the category of malignant tumors. So we are discussing few brief points about the resection, and then we will discuss the reconstruction also. So these are the general points about the chest wall resection. So important points here. The first very important point in resection is localization of lesion. Because the localization of lesion is very, very important. Sometimes lesions are very small and they are not visible clearly. So that's why the review of the images before surgery and must discuss with the radiologist for the localization. Sometimes the patients are coming after chemotherapy and they are responding very well to chemo and they regress in size. So important to localize the lesion, and sometimes you need to localize lesion by needle localization with the help of ultrasound or CT guided needle localization. And open and interspace means when you operate these patients and the tumor margin, resection margins are important. So you space open the one or two spaces above the lesion. Is from inside you prepare the tumor and get resection margin clearly 2 or 4 centimeter depending on the nature of the tumor. Because the negative microscopic margins are required for malignant tumors, extensive resection result in paradoxical chest wall movements. Thus, the rigid chest wall reconstruction is important, and that can be done by methyl acrylate bone cement sandwich between two layers of polypropylene mesh. The mesh should be extended over the edge of rigid part of the sandwich to allow suturing to the non-absorbable material. So it's clearly shown here in picture. So this is the proline mesh, and the methyl acrylate bond cement here is between two to provide the rigidity of the chest wall. And this edge of the mesh has been shown. It's helpful to fix the mesh to the chest wall. So this provides the stability to the chest wall. Here, another example of the methyl acrylate bone cement between two layers of the proline, and especially when we resect the sternum and there are sternal tumors, so it provides the contour of the sternum. So and this contour provides at the sternal site shown here, and you can see nicely it mimics that it's same like sternum. This is another example of chest wall resection. This patient, he was a 12-year-old boy and with a large chest wall osteochondroma. It's shown here. And radiologically, it's visible a 3D scan showing large lobulated calcified mass. And this huge tumor was resected. You can see here by the anterolateral thoracotomy, and this is the follow-up picture. This is another example of the soft tissue tumor lipoblastoma in a newborn baby, and it's visible in chest x-rays as soft tissue shadow. And this is the post-resection scar showing, because you see the tumor is not visible here. This is the Ewing sarcoma. You can see the chest wall is involved in extending into the intrathoracic compartment, involving the left hemithorax. And this is the chondrosarcoma involving the sternum. It's visible in this position, patient in supine position here. These are few tips of chest wall resection and reconstruction. Anti-chest wall resection may significantly alter the respiratory physiology depending on whether the entire sternum is involved, the size of the defect, and the type of reconstruction. Meticulous preoperative planning is necessary to effect the radical resection and reconstruction according to the principles. CT imaging reconstruction sometimes very helpful, and as we have discussed, because the tumor margin assessment is important, sometimes we introduce the thoracoscope, and with the help of thoracoscope VATS, and we can identify inside the tumor, because sometimes the tumor is externally visible smaller and from inside they are large. So resection margin can be located with help of these thoracoscope VETs. And the decision of about the reconstructive surgery is individualized, because sometimes even in case of the one rib resection, although normally we don't need to reconstruct the chest wall in these patients, full thickness reconstruction is not required in every case, but sometimes when the patient is athlete, because there are chances of the herniation through that defect, and they may need reconstruction. Otherwise, normally for single rib resection, there is no need of chest wall full thickness reconstruction. And for malignant primary chest wall tumors, the immediate adjacent rib should be resected for the corresponding length of infiltrated segment on tumor-free margins, usually because one rib above and one rib below the tumor should be resected to get the clear tumor-free margins. And when the manubrium or clavicles are involved, these can be removed without subsequent reconstruction. The materials for chest wall reconstruction, we can use the polypropylene and polyglactin mesh, and with methyl acrylate bond cement, along with the polytetrafluoroethylene patches over materials. And sometimes we need the titanium plates to replace the ribs. And acellular collagen matrix meshes and corresponding homografts are increasingly being preferred due to the resilience to infection and ready incorporation into the host tissue. Here we will discuss now partial thickness resection. This is the technique. The skin resection should be kept at a safe margin 2 to 3 centimeter from macroscopically visible tumor edge. When the tumor is ulcerated, the cutaneous incision should be at the same distance from inflamed area. The muscular layer are divided along an oblique line directed away from the tumor so that the in-block specimen resembles the truncated cone. If possible, the subcutaneous fat tissue should be spared as reinforcement for subsequent primary or secondary closure. The dissection is started by sacrificing the periosteum of uninvolved ribs. In the event of multiple local recurrences or previously radiated area, the costal plane is adherent to elevate the overlying pectoralis muscle. Therefore, the specimen is suspended cardiocranially and divided laterally and medially to identify and divide main vascular supply. This picture shows how the partial thickness reconstruction resection is possible. This is truncated cone, means the from above the cone shaped resection and go downward and resect in this way that reconstruction will be feasible in this truncated cone resection. And the periosteum is removed from the ribs. In this picture it's showed the periosteum has been removed from ribs, and the myocutaneous layer containing the tumor are elevated and divided on soft margins. So elevate the tumor and resect all around. So in truncated cone resection, that it will be easy for reconstruction in partial thickness especially. And the reconstruction in these partial thickness resection is in straightforward cases, just primary closure is possible by subsequent undermining the wound edges. Because just soft tissue is there, we do not remove the ribs, and in these cases, just either you close it primarily or you may need skin grafts. But sometimes the sizable defects are covered by rotation myocutaneous flaps or VY advancement flaps, which enable the surgeon to cover the extensive anterolateral defect and permit adequate approximation of donor wound edges. A triangular shaped skin island based on elevated latissimus dorsi is rotated. It's shown in figure 2. I will show you in figure 2A. The layer-to-layer suturing, laximus dorsi is to surrounding muscle in the recipient area, is usually sufficient to maintain the flap in place without anchoring it into the underlying ribs. Alternatively, when the skin is spared to permit a primary closure of partial thickness defect, a laximus dorsi flap can be raised and rotated anteriorly. So in this picture, you can see here a VY advancement myocutaneous flap is rotated to cover the anterior chest wall defect here, and it will cover here, and then you can close primarily this area. If the wound can be closed primarily, only the laximus dorsi flap is raised and tunneled to cover the anterior defect. Here, only just the laximus dorsi muscle flap has been raised and cover the defect. The challenging thing is full thickness resection. The uppermost intercostal space is open. The first important point is start from virgin area. The uppermost intercostal space is opened by electrocautery, diathermy. Keep it in contact with superior border of the upper rib to prevent the injury of the neurovascular bundle. Once the lowest rib to be removed is identified, the intercostal space is opened by diathermy along the superior border of immediately inferior rib. The finger palpation or thoracoscopic, as we have discussed, we can use the either the VATS thoracoscope, or we can use the finger to palpate because we open the virgin area, we can see from inside the tumor. Now decide where to resect because now you can see the external and internal surface of the tumor, and definitely the section margins are decided. The intercostal vessels are ligated because when you resect the ribs, definitely the intercostal muscles, vessels, and nerves are coming, and you ligate the intercostal vessels to prevent the bleeding post-operatively. By performing anterior and posterior costomies, when you resect ribs, bony segments of sufficient length to ensure the tumor-free margins are resected along the corresponding intercostal muscles. The important point here is because in bones, when we remove ribs, because the frozen section is not possible of bones immediately, so that's why we should be careful. We at least take 4 centimeter margins in case of sarcomas. This is the picture showing here the full thickness resection. The intercostal space is entered and the flash to superior edge of the uppermost border removed. You can see here, and the ribs are resected here. This is a tumor. This is the tumor-free margin. Macroscopic margins is visible here, and the neurovascular bundle is intercostal vessels, and neurovascular bundle is visible here. It should be ligated, and this rib is resected from here. So we should go above the tumor and enter into the pleural cavity and then resect the tumor-free margins laterally, superiorly, and inferiorly. Now, important point, which is challenging for every surgeon here, is full thickness reconstruction. Because when we resect ribs, definitely there is a paradoxical movement, and because of that, the patient may have problem change in physiology of the respiration, and they may have problem in respiration. They may need ventilator support sometimes. And another challenge is the shape contour of the chest wall. So the materials that we can use is the polytetrafluoroethylene and methamethyl acrylate sandwich, MMM, triple M, have proved to serve this purpose because these are the materials that support the chest wall and preventing the paradoxical movement. When polytetrafluoroethylene is used for extensive anterior chest wall defects requiring rib resection up to the entire lateral aspect of the sternum, the reconstruction will be based on a series of external punches going through the sternum, because we must punch the sternum and we fix the PTFE patch through the sutures, and we cross through the sternum when we punch the sternum. So it will fix over there and provide rigid stability to the chest wall. And however, the titanium plates in association with acellular collagen matrix or cryopreserved homograft could be viable alternative for reoperations and heavily irradiated areas, because sometimes the radiated area has damaged a lot of the normal chest wall uh, structures. So that's why they may need more stabilization, and we can stabilize these remaining ribs with the titanium plates. I will show you in picture. So a combination of titanium plates and acellular collagen matrix can be used. So we can use these patches and methyl acrylate bond cement sandwich. We can use the titanium plates. Here you can see in this tumor has been resected. Now this is the complete defect. The pleural cavity is open, lung is visible here. Here is the acellular collagen matrix patch we have applied here, and for fixation, the patch should be fixed through the rib, and we should make holes here to cross these sutures to provide the strong rigidity to the chest wall. Here, in combination with this acellular collagen matrix, we use the titanium plates, and we should fix these plates with the remaining ribs, and 2 to 3 screws are sufficient to give stability to these titanium plates over the ribs. And over these titanium plates, we can use this mesh again to prevent the erosion of the overlying muscle and skin. Here, this was about the chest wall, and here is the anterior chest wall. Here is the sternum, because sternal resection is one of the very challenging for surgeons here, because if the sternum needs to be removed, the division of the bony ribs start laterally on the side opposite to the most severely involved by sternal neoplasms. The width of lateral extension is directed by need for safe tumor-free margins, because we do not compromise on the tumor margins. So we should consider that tumor-free margins are required, so reconstruction is possible by different ways. And if the tumor infiltrates the body of sternum symmetrically, the resection is started on left side. Here, the tumor is, for example, is on the one side, then we start laterally on the opposite side. But when the tumor is symmetrically involved, we should start from left side and then carried out the counterclockwise to level of the same contralateral rib in U-shaped fashion. In any case, the chondrocostal release is performed up to at least one intercostal space superior to macroscopic appearance for the tumor. The internal mammary vessels are routinely identified and ligated. The intercostal pedicle is usually dissected through an extra periosteal route. However, if the primary tumor is chondrosarcoma, the periosteum should be included in the specimen, because the lymphatics may represent a possible route for local recurrence and metastatic dissemination, especially in chondrosarcomas. As the separation of sternum from the ribs continues, the specimen is suspended, thereby allowing for visualization of the mediastinum, because underlying vital structures are there. We should elevate the sternum, and under vision, we should see the mediastinal structures like arch of aorta and trachea, pericardium, and pulmonary vessels are there, and the mediastinal pleura in lungs. Sometimes in ventilating lung, you get even the lungs are coming in way. So if the tumor involves the upper sternum chest, the sternotomy incision is carried laterally onto the clavicles in a T-shaped incision. I will show you in picture how this T-shaped incision is this. The clavicle are dissected in the subperiosteal plane to avoid injury to adjacent vessels. The finger dissection is needed to break the retroesternal ligament behind the manubrium, and the memory pedicles are usually divided. Here you can see how we give T-shaped incision when the tumor is the upper sternum. Here the tumor is in the upper sternum. We should give incision like this over the sternum, and we extend this incision in this way to cover the resection margins all around, and we should resect these costal cartilages. So this will be the defect. So defect can be reconstructed, but we should not compromise on tumor-free margins. Here, now the external reconstruction. So again, variable options are available for post-sternectomy stabilization. The selection of reconstructive material depend on the size of defect, obviously, on previous irradiation or surgery, on concurrent infection, and on whether the manubrium is preserved or not. If the sternum is completely removed up to the clavicles, the anterior chest wall stabilization can be achieved by means of polytetrafluoroethylene and methyl acrylate processes. If the manubrium is spared, a neosternum is created by fitting a cryopreserved homograft like iliac crest. So neosternum is locked into the manubrium and titanium screw. Drill or external punches is used to accommodate the non-absorbable suture, as we have discussed, and we should fix it, the patches, with the sternum with the help of sutures. Other cryopreserved homograft can be used are ribs to bridge the defect of the sternectomy, or cryopreserved ribs are fixed to native lateral rib segment through either K-wires or sternal plates. Cryopreserved homograft may require an omental vascularized bed to facilitate vascular inosculation and progressive incorporation into the host. The same technique is used to protect the mediastinum when titanium plates are selected to bridge the post-sternotomy defect. Omentum is preferably raised through the upper midline incision. We should give midline incision. We should remove the omentum, and the patch of the omentum should be placed over the sternum, and even over the titanium plates and patches, and under the titanium plate and patches, because to prevent the mediastinal structures, and above it prevent the skin erosion. A potential alternative to omentum flap is represented by a combination of titanium plates and acellular collagen matrix. If the defect is in the lower sternum, the rigid stabilization may not necessary in this case. It might be sufficient to raise the pectoris major muscle bilaterally and approximate them on central line through covering the defect with viable tissue, as shown in this picture. You can see here, this is the first picture when the complete defect is there. This is the patch, new homograft, and methyl acrylate sandwich bond cement is applied here with fixation of this, and this is the midline incision to remove and apply here over the under the and over the defect. Here you can see the omentum flap passed into the mediastinum. Here it's placed. This is this in case of the lower sternal defect. The pec major from left side and right side has been mobilized and stitched. Now, after anterior and chest wall defect, resection, reconstructions, and now the lateral chest wall, because sometimes the lateral chest wall defects are the larger and smaller because the bulk of the muscle is available. Sometimes we use the pec major, the latissimus dorsi or serratus anterior for reconstruction here. So here is an example. The medial edge, this is the medial edge of the scapula, fourth rib with tumor underneath here. Here is the tumor, you can see here. So thoracotomy in the fifth intercostal space here. So we should identify the undersurface of the tumor. And now the tumor is being resected with the clear margins. This will be the full thickness resection. Now this is the resection of the ribs. Here you can see now we are fixing this patch with this. This is the Gore-Tex mesh with the ribs. Pericostal or through the ribs, we can apply these sutures and fix this patch. Okay, now in conclusion, nowadays a versatile individualized approach to both primary and redo resections for chest wall tumor is possible. And meticulous technique and adherence to the concept of structure and function of chest wall will achieve optimal results. Economic issues, especially in our country, we should consider because few materials are very costly, and we should consider the financial status of the patient, and we should keep our mind that what material we can use, and as we can help more and more patients. So taken in account, these should be taken in account when selecting the most adequate material for reconstruction. The redo operations often require a combination of material in light to extension of recurrent tumor. The most important, last and most important point is because in these patients, we should consider that multidisciplinary team meetings, we should present these cases, we should take opinion of radiologists, pathologists, surgeons, oncologists. So we should discuss in tumor boards, in surgical meetings for proper management and expert opinion of different specialties. Thank you very much. These are references.
Thank you so much, Dr. Niaz. Now, forum is open for questions. Dr. Niaz Soomro is available to answer the questions. And I'll begin with my question, hearing to your presentation. As a pediatric surgeon, I am afraid of these prostheses, the titanium plates, the meshes, because we know that children are going to grow and they are going to outgrow the size of the meshes. So, what is your experience in case of pediatrics? How is the long term how are the long term problems managed in these cases? Like, for example, as the child grows, the defect grows and it outgrows the margins of the prosthesis. So how to deal with that problem?
Um, Thank you very much, Dr. Aqil. I'm very thankful for the Indus team for giving me opportunity to present these difficult part of the thoracic tumors and chest wall tumors. So, Dr. Aqil, because when we reconstruct the chest wall in the, can you hear me?
Yes, we can hear you very well.
Okay. Okay. When you reconstruct chest wall, whatever the material you are using, you consider at that time the contour in defect of the child at that time how much the defect is. But when the child will grow, because the contour is maintained according to its body shape and the size of the body. But when the child will grow, the what happens, the rest of the part of the chest will grow, and the reconstructed part will stable there. So with the time, the deformity of the chest wall may become prominent, but it's not a problematic because the important point in reconstruction is to prevent the paradoxical movement and to maintain the respiratory physiology. Definitely, this happens in children. The deformity may be visible when the child grow, but physiologically, but anatomically, the physiologically, it will not affect on the children. but anatomically this may prominent with the growth of the child. I cannot hear you, Dr.
Sorry,
Aqil.
sorry. Now you can hear me. I did not turn on my
Yeah.
mic. Uh,
Okay.
uh, uh, my question was the second question was related to your since I worked with you in a couple of tumors and I saw you mobilizing flaps. Personally, I feel that flaps or the native tissue of the child, if we can bring it, that would be that would be a more better choice than prosthesis. My personal feeling. So what is your take about it? Do you prefer, like, what is your preference in terms of native tissue and prosthesis?
Definitely, the natural native tissue is always better than the prosthesis. This is the one this choice of the every surgeon, and we try to use the native tissue always. And the prosthesis is always used because I discussed there are two types of resection and reconstruction. One is the partial resection and reconstruction, and other is the full thickness reconstruction. Whenever there is a partial resection and we need reconstruction in a partial defects, the better and best option is the native tissue, the muscles. We do not use most of the times the processes, but in case of the full thickness resection, because we are removing the ribs and definitely there is a defect, so in those cases we try to use the processes. And in processes, we just try to use, instead of the titanium plates, we try to replace give stability to chest wall with just with the mesh. And but in case, for example, the defect is very large and the we have removed 5, 6, or 7 ribs, for example, so it's difficult for the mesh to maintain the stability of the chest wall. In those cases, we may need the titanium plates to give good strong stability to the chest wall.
We have a question from Dr. Hannah Arbab. Are there
Yeah.
processes that can grow or allow for less deformity, which are like tailor made for pediatrics?
uh, Dr. Hannah. So I never heard about the growth of the processes yet, because this is the selection of the processes, but I never heard about the growth of the processes with the time. May you have experience, you heard from somewhere, but still I don't have experience of that.
Actually, in pediatrics, we are people have been using biodegradable meshes. People have been using collagen meshes or collagen like patches as an scaffolding. So probably her background of question may have been that. Uh, 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 Another question from Hannah. Also, are there physical rehab therapies that allow for decrease in this deformity?
Uh, Dr. Hannah, yes, partially it can affect, but when we use these prostheses and the child is growing, that defect that has been covered by these prostheses will remain over there. But from the when they are doing the physio rehabilitation, yes, with rehabilitation, sometimes few exercises we can the deformity can be covered, but not as because the that with the rehabilitation, the defect that was covered with the processes will not grow, will not give shape to the chest, because the rest of the normal tissue can be managed by physio and rehabilitation, but the processes will not affect with rehabilitation. Mike, please. Dr. Akil,
Thank you so much, Niaz. You were kind enough to like spare time, you being away from home. Hannah has thrown another question.
yeah.
How how radical can we go when doing chest wall resection? Is there a limit to how far we should go?
Yes. This is very good and relevant question because I forget to discuss this, and because in cases of sarcoma, and most of the surgeons and you may have the experience, there are chances of recurrence more is compared to the soft tissue tumors. So whenever we are dealing with the bony tumors and especially sarcomas, we should take at least 3 to 4 centimeter margins. So we should be radical. We should not compromise on the resection margins whenever we are getting these types of tumors. But for example, in case of benign tumors, no need to go beyond 1 or 2 centimeters because in those cases, their chances of recurrence are less. They are benign diseases. Most of the times, they do not need any adjuvant or new adjuvant. So why to resect radically more and more chest wall? So better to save the normal chest wall structures. But in case of the tumors which are malignant one, and especially those tumors which the chances of the recurrence are more in those tumors, and definitely we should not compromise on the size of the defect, because the our priority should be the resection of the tumor with clear margins. We should not compromise on 1, 2, 3, or 4 centimeters. We always take tumor-free margins because the if you will reconstruct the 2 centimeter defect or 5 centimeter or 8 centimeter defect, and you will reconstruct 10 centimeter defect, no problem, because 2 centimeter can be covered with the processes, different type of processes. But if you will compromise on the tumor margins, so there will be the vestige of your time and energy, and the patient will not get benefit of that reconstruct surgery. So never compromise on tumor-free margins. Go radically, and you show your aim and basic principle. The clear margins must be there, and reconstruction will be there and possible in every type of the defect.
And another question, Hannah. Hannah is quite active with thoracic
No, no, no,
problems.
yeah.
So, do we go back in case if margins are not tumor free?
Yes, always. We should. We should, because what happens, I discussed in last point of my conclusion, because we should discuss before surgery and even after surgery these cases in our tumor boards, and we should use the expertise of the experts, and we discuss with them in tumor boards. For example, few tumors are radiosensitive and chemosensitive, and if the oncology team is agreed that they can cover this with the chemo or radiation, no need to go back to surgery. But for example, if the tumor is chemo or radio resistant, then definitely you have to go back.
Thank you. Thank you so much, Niaz. It's always pleasure talking to you and working with you.
Thank
And
you.
with
Thank you
this,
very much.
we end our session. Thank you so much all for your patient listening and hearing. Allah Hafiz.